Okay, so in this session we're going to provide an overview of urinary incontinence. We're going to talk about how different types of incontinence and voiding dysfunction are classified. We're going to provide an overview of pathology, clinical presentation, diagnosis, and management. So this is a big picture class. Now I want you to realize that we're going to cycle back around. We're going to talk in detail about how to assess an individual with urinary incontinence. We're going to talk in detail about how to manage the various types of incontinence. So this is more of an introductory class just to give you kind of the lay of the land so you know what we're talking about. So you know, and I know, that urinary incontinence is very common. In the past, it's frequently been given very little attention, partly because it wasn't considered to be a medical problem. But now we have increasing data about not only the prevalence of this condition, but also the impact. So looking first at prevalence. Current data suggests that at least 20 to 50% of community-dwelling women and elders are incontinent. 47 to 70% of elders in long-term care are incontinent. And we know there's a significant impact. We have increasing data that link incontinence to increased risk of falls from patients trying to get up to get to the bathroom and slipping if they have leakage. There's a link between incontinence and urinary tract infections, and there's definitely a link between incontinence and skin breakdown. So more and more it's being recognized not only as a hygienic issue, not only as a psychosocial burden, but also as a potentially significant medical issue. As nurses, we're very well equipped to deal with both the medical issues, the physical issues, and the psychosocial issues. When you work with patients who have incontinence, you become very aware that even though skin breakdown, urinary tract infections, and the potential for falls are a significant concern, the psychosocial impact is much greater. Patients will tell you about limiting activity, not going to events that they truly want to go to because they're afraid they'll embarrass themselves or their families. Not going to church because they're afraid they'll wet the pew. Toilet mapping, knowing where every toilet is and limiting out-of-town trips because they don't know where to stop and where they can go. So anything that we can do to improve continence or to make incontinence more manageable goes a long way to improving these individuals' quality of life. So in looking at classification systems, you want to begin with differentiating between incontinence that is newly occurring and potentially reversible and incontinence that is established. By definition, transient or reversible incontinence is incontinence caused by factors that can be corrected. However, we know that many individuals who have established incontinence, long-term patterns of leakage, have reversible factors that are making their incontinence much worse. So the bottom line implication for us as nurses is whether we're dealing with a patient who has new onset incontinence or whether we're dealing with a patient with established incontinence, we should always begin by assessing for and correcting any reversible factors. Many times that makes a huge difference, even if it doesn't solve the problem in its entirety. So let's look at reversible factors. There are several mnemonics that have been developed to help us remember reversible factors at the bedside. And one of the ones that's widely used and that is used in your core curriculum text is the mnemonic toileted. So that's the one we're going to talk about here. In this mnemonic, the first T stands for thin, dry, vaginal, and urethral epithelium. This is also known as atrophic urethritis, atrophic vaginitis, and urogenital atrophy. Now, what impact does this have? Well, from a visual assessment perspective, you can see changes in the vaginal and the urethral epithelium. Normal, well-estrogenized vaginal mucosa is going to be deep pink or red. It's going to be rugated and moist. Atrophic vaginal epithelium will be smooth, it's frequently pale, it's dry. In some cases, it looks very inflamed. It's bright red with an inflamed appearance. Normally, the urethra is not even very visible, so we don't typically even assess or note the urethral epithelium because we can't visualize it. It's internal. But in women who have significant urethral atrophy, the urethral epithelium can become extremely hypertrophic, and this is known as a urethral caruncle. It actually looks almost like a miniature stoma at the urethral meatus, and it's from hypertrophy of that very inflamed tissue. In addition, women report signs and symptoms that indicate urogenital atrophy. So pain with intercourse, vaginal itching and dryness and discomfort. But more relevant to our discussion of incontinence, women frequently also report increased urgency, increased frequency, and increased risk of urinary leakage. I have a very good friend who's perimenopausal, and she had essentially no symptoms except she noticed increased urgency, increased frequency, and sometimes slight leakage if she didn't get to the bathroom in time. She's a busy WOC nurse. She's like, I have no time for this. So she went to the doctor, and he said, well, I'm going to put you on some topical estrogen. And she's like, really? You think that's going to take care of it? He's like, well, it's a very good first place to start. Put her on topical estrogen, totally eliminated the problem. She had not specialized in continence. She had forgotten about the link between estrogen levels and bladder function. So in addition to causing vaginal discomfort, in addition to potentially causing a urethral caruncle, estrogen deficiency can cause urgency, frequency, and leakage. In addition, you should know that estrogen deficiency is associated with increased risk of urinary tract infections in older women. Now, so far, all of the studies regarding this phenomenon have been done in long-term care. There's certainly no reason to think that that would not hold true for women in the community. And anecdotally, I have talked to both patients and providers of community-based women who have had recurrent UTIs during postmenopausal years and whose UTIs were eliminated by use of topical estrogen. So does estrogen make a difference to the health of the female urogenital tract? Definitely. Urethral tissues, vaginal tissues, and the tissues of the bladder base are all estrogen dependent. Restoring estrogen levels to at least some extent can go a long way toward reducing urinary tract problems as well as vaginal problems. So if you have a female, she's postmenopausal and she's having symptoms. She's having urgency and frequency and leakage. She may be complaining of some vaginal symptoms as well. She has evidence of urogenital atrophy on physical exam. Then it's worth a trial of topical estrogen. Now, topical estrogen, you should know, is just as effective as systemic estrogen in restoring the health of those tissues and in relieving symptoms of urogenital atrophy. However, topical estrogen has a much lower incidence of side effects. So we sometimes say you get maximum benefit and minimum adverse effects. In beginning topical estrogen, you can use any of the forms that are on the market. You can use the creams, you can use the intravaginal tablet, or you can use the S-ring, which is a little intravaginal ring that releases estrogen at a sustained rate for 90 days. If the woman has significant urogenital atrophy, if she's symptomatic, you probably want to begin with a loading dose, which typically involves treatment daily for 2 to 3 weeks, and then placing the woman on a maintenance schedule, which is usually about twice a week for the tablets, the intravaginal tablets or the cream. Or once you get to maintenance level, you could put her on the estrogen. So bottom line, estrogen is important to urethral health and vaginal health. Estrogen deficiency can cause urethral symptoms and can cause irritative bladder symptoms like urgency, frequency, and leakage, in addition to causing vaginal discomfort and problems. Topical estrogen is very safe. About the only contraindication is a history of breast cancer. Other than that, very safe, so worth a trial to see if it's beneficial for this patient. The O in toileted is obstruction, and specifically we're talking about stool impaction, chronic constipation that creates a degree of obstruction to urethral emptying. So when you think about the fact that the bladder and the urethra and the rectum and anal canal are essentially next door neighbors, you can see that if the rectum is chronically full of stool, and especially if it's overfull, if it's distended, if there's impacted stool, it's going to compress the urethra and make it very difficult to get complete emptying. If you don't empty completely, then you get into a degree of retention, which leads to frequency, urgency, possibly leakage, possibly urinary tract infections. The other thing is that impaired emptying increases bladder irritability. The bladder doesn't like it when it's trying to empty and it can't get the urine out because there's a bunch of poop in the way. So it becomes increasingly irritable, and that's manifest as frequency and urgency. So every time we do an assessment on an individual with urinary incontinence or voiding dysfunction, we always ask about bowel function. How often do your bowels move? What's the consistency of your stool? How often do you have to take a laxative? And sometimes patients are like, why are you asking me all of these questions about my bowel? That's not what I'm here for. We're like, because your bowel and your bladder are next door neighbors. And if your bowel is not functioning normally, it's going to cause problems for your bladder. Sometimes I'll explain to a woman who has children, who I know has been pregnant. I'll say, remember when the baby was sitting on your bladder? Oh yeah. How often did you have to go urinate? All the time. My bladder couldn't hold anything because that baby was sitting right on it. Like, well, now it's not a baby, it's poop. But it's having the same effect, and we got to get it out of there. So anytime that there's evidence of constipation and or impaction, you want to start with a bowel clean out, and then you want to get them onto a bowel management program with fiber and fluids to prevent recurrence. The I in toileted is for infection. Now, infection does not cause urinary incontinence, but it can be a contributing factor. For any of you, if you had a urinary tract infection, it would cause you frequency and urgency, but it would not cause you to have leakage. However, what if you were older? And what if you were less mobile and it took you longer to get to the bathroom? Then if you add frequency and urgency to that mix, yes, it could contribute to leakage. So it's a contributing factor, not a causative factor. That means we always ask about signs and symptoms of urinary tract infection. If we have any reason at all to be concerned, we do a dipstick. And if it's symptomatic UTI, we treat. Now we'll come back to this because it's very important. The current guidelines are do not treat asymptomatic bacteriuria. So if I do a dipstick on this patient and it comes out positive for nitrites and positive for leukocyte esterase, but I ask the patient, do you have any suprapubic tenderness? And I palpate and percuss, no tenderness. Flank tenderness, no. Has there been any change in your physical function, in your mental function? No. Have you noticed your urine being bloody, cloudy, anything like that? No, not really. That patient's asymptomatic and I would not treat because it's not going to help. And it is very likely to create bacterial resistance. In contrast, if I have a patient who comes in and they're reporting new onset incontinence or sudden worsening of their incontinence, and they do have suprapubic tenderness or flank tenderness, and I note malodorous, cloudy urine, and the family member says, you know, mom's been kind of fuzzy the last few days. She's not herself. She's not as mobile as usual. She's not as alert as usual. That is symptomatic UTI, and I would treat. So you always ask about signs and symptoms of UTI, screen for UTI, and you treat if it's symptomatic. The second way that I is sometimes used is to denote irritants. Now, this is one of those areas where our data is very limited. So the data that we have suggests that for some individuals who are susceptible, caffeine can be a bladder irritant, nicotine can be a bladder irritant, carbonated drinks may serve as a bladder irritant, aspartame may be a bladder irritant, and possibly citrus beverages. We don't have great data on this, so this is based heavily on anecdotal reports. But if we have a patient who's complaining of urgency and frequency, and we review their fluid intake, and we find that they're drinking a lot of carbonated fluids with aspartame, and they're also taking in a lot of caffeine, and possibly they're smoking, it's worth sitting down and talking to them about the potential role that these substances have on bladder function. In susceptible individuals, what seems to happen is that intake of these substances sensitizes the stretch receptors and the muscle fibers in the bladder wall, so it actually makes the bladder feel and act full at lower volumes. So if I talk to a patient who's having urgency and frequency and possibly some leakage, and I find that they have very high intake of these substances, I'm going to talk to them about doing a trial reduction to see if it makes a difference. If it makes a difference, then they may elect to avoid those fluids or reduce those fluids on a long-term basis. If it doesn't make a difference, no point in restricting those fluids. So if someone says, what does the I in toileted stand for? It stands for infection. But don't forget to talk to patients about the potential role of irritants. L is for limited mobility, and this is pretty obvious. If I have to use a walker, if I have to use a cane, if I'm very slow to get from my chair to the toilet, and I have urgency, I'm much more likely to leak on the way. If I can get there in 10 seconds or less, then I'm probably not going to leak. But what if it takes me 2 minutes or more? So we're always alert to mobility issues. We're always thinking, should I get this patient a bedside commode? Should I get this individual a urinal, this gentleman a urinal for use at night? What can I do to make them and the bathroom closer? The first D in toileted stands for emotional issues, so we know that there's a link between depression and urinary incontinence. First of all, depression involves a depletion of the same neurotransmitters that play a role in sphincter function. And there's some data to suggest that patients who are clinically depressed have a higher incidence of stress incontinence. Also, incontinence itself can cause some degree of depression. So the take-home message for us is to always screen for depression. If that patient is found to be depressed, to either treat if you're an NP or refer if you're not advanced practice. And to think about when you're treating a woman for depression, think about treating with duloxetine, because that's the medication that has been shown not only to improve clinical depression, but also to reduce the frequency and severity of stress incontinence. T is for therapeutic medications. Many medications can impact on bladder function and on sphincter function. So whenever we're doing a screening assessment, we're always going to get a list of the medications that this patient is taking. over-the-counter medications, prescription medications, herbal agents. If you have a lot of elderly patients and they're taking a lot of medications, it can be overwhelming to think about looking up each of these medications to see what impact they have on bladder function. But frequently you can enlist the aid of the pharmacist who has software programs, and he or she can screen for adverse effects on bladder function. Here we've given you a short list of the most essential medications to consider. And I think it's very helpful to look at medications from the perspective of this patient's problem. Is this patient having a problem with leakage, or is this patient having a problem with retention? If they're having a problem with leakage, then you're screening for diuretics, which of course increases urine production. You're screening for sedatives, which might make it harder for them to recognize bladder filling and to respond appropriately. You're looking for alpha-adrenergic antagonists like tamsulosin, which would open the bladder neck and increase the risk of leakage. And you want to be alert to ACE inhibitors, which can cause leakage because of that constant dry cough. In contrast, if your patient's problem is with emptying, they're having problems with emptying, they're in some degree of retention, you're going to look for anything with an anticholinergic component, because anticholinergics relax the bladder wall. Well, anticholinergics are components of many medications. Antidepressants is one category. Many of your drugs do have some anticholinergic components, so you want to be very alert to that and ask the pharmacist to screen for that. You would also be very alert to decongestant medications like pseudoephedrine, because that's going to tighten the bladder neck. The second E in toileted is for endocrine disorders, so you're going to screen for anything that would tend to increase urine production. Two things that come to mind: poorly controlled diabetes mellitus with resulting hyperglycemia, and diabetes insipidus. Both of those conditions are associated with polydipsia, so people are drinking a lot more, and with polyuria. And if you're having excess urine production, it's easy to see how the bladder and the continence mechanism could become overwhelmed, and you might have increased frequency and increased risk of leakage. If that patient does have either type of diabetes, obviously the critical intervention is to diagnose it, treat it, get their blood levels back in the normal range so that you eliminate polyuria. And finally, D, delirium. Delirium, as you know, is different than dementia. Delirium is a reversible alteration in mental status. Dementia is non-reversible. Critical to realize that you can have delirium superimposed on dementia. So you can have an underlying dementia and a superimposed delirium, which would be manifest by sudden worsening of a patient's cognitive status. Multiple causes, you know, infection's a big cause. In the elder population, urinary tract infection is one of the most common causes of cognitive decline, sudden cognitive decline, altered mental status. So you're very alert to any signs of infection, to any electrolyte abnormalities. Medication's another common cause of altered mental status. So if you have someone who was continent last week, they're incontinent this week, or their leakage is much worse this week, then the big thing to determine is what made them worse, what caused the alteration in their mental status, because once we fix it, then they're going to go back to being continent. So if you were okay last week, confused and incontinent this week, I've got to address your confusion. Treat your infection, correct your electrolyte abnormality, whatever. Okay, I know this thing will click. Okay, so now let's talk about established incontinence. What is it by definition? Well, established incontinence is incontinence that persists 6 months or more past the correction of any reversible factors. So So either I had no reversible factors and I'm still incontinent 6 months later, or I did have some reversible factors, but you fixed them all at 6 months later and I'm still incontinent. If I have persistent incontinence, your goal is to determine what kind of incontinence I have so you know how to proceed with management. So the next section in this discussion is going to look at the different types of established incontinence. I'm going to go back to something we discussed in our first class when we said that the voiding cycle has two distinct phases, the storage phase and the emptying phase. I'm going to link the common types of incontinence and the common types of voiding dysfunction to the specific part of the cycle that's involved. So looking at failure to store. If you do not store normally, it means you're leaking, right? You have incontinence issues. Stress incontinence is a sphincter problem that causes leakage with activity. In contrast, overactive bladder is a bladder problem that causes frequency and urgency and potentially leakage. There's another type of incontinence due to functional factors. So there are patients and their bladder works normally and their sphincter works normally. The problem is their brain doesn't work normally, or they have major mobility impairments. If my brain doesn't work normally, then I'm not going to recognize bladder filling. Even if I'm vaguely aware that something's going on, I'm not going to be able to problem solve to get to the bathroom in a timely manner to void. So when you say that this person has functional incontinence or incontinence due to functional factors, you're saying nothing really wrong with the bladder, nothing really wrong with the sphincter, but there are functional factors that are causing incontinence. Extraurethral incontinence we're really not going to spend time on. This is incontinence caused either by a fistula, such as a fistula between the bladder and the vagina, or in men between the bladder and the skin. Or in a child, it could be caused by an ectopic ureter that bypassed the sphincter. Bottom line, if you have extraurethral incontinence, the only way to manage it is to either correct the underlying problem surgically or to manage them with absorptive products. So we're not going to spend much time on extraurethral. And then finally, enuresis, which is a pediatric condition, is bedwetting past the age at which nighttime continence is typically obtained. And that, again, a storage issue. Now let's look at the other side of the cycle, the emptying cycle. If you have problems with emptying and you have any degree of retention, that is known as voiding dysfunction. And finally, neurogenic bladder dysfunction can cause problems both with storage and with emptying due to complex neurologic lesions that interfere with communication between the brain and the brainstem and the bladder and the sphincter. So we're going to talk about each one of those. And we're going to talk about what is it, what causes it, how does it present clinically, how is it diagnosed, and overview of management. But remember, this is kind of your overview of each type, and we're going to cycle back around and talk about each type in a little bit more detail in terms of management. Stress incontinence. You definitely want to understand stress incontinence. It's one of the most common problems in this country, or really around the world. And most of you are women, and so that means that you're at risk for stress incontinence. Even if you're male, you probably have a sister, a wife, female friends, and they're at risk. So a good way to think of stress incontinence is activity-associated incontinence. Women who have stress incontinence do not leak when they're sitting. They don't leak when they're just standing. They don't usually leak when they're just walking around doing chores. They leak during activity that causes an increase in abdominal pressure and downward pressure on the bladder. So they leak when they cough, or they laugh, or they sneeze, or they lift, or they jump, or they jog. The basic problem is with the sphincter. The sphincter does not maintain a watertight faucet. It allows urine to pass through. So at rest, the sphincter is fine, but as soon as it's stressed, as soon as there's downward pressure on the bladder, higher pressures within the bladder, the sphincter is unable to compensate and permits leakage. Very important to realize the bladder is not part of the problem here. If you ask the patient, when you have leakage episodes, do you have an urge to go? Are you trying to get to the bathroom? She's going to say no. She might even say, no, I went to the bathroom just before I started exercise class. And then as soon as we started jumping, I started leaking. So it's not a bladder contraction that's causing the leakage. What's happening is that activity is causing an increase in abdominal pressure, which is pushing down on the bladder and increasing bladder pressure, and the sphincter is unable to compensate. Now, there's three major types, I guess. No, types is not the right word. There's three major causative factors for stress incontinence, for this activity-induced incontinence. In women, the most common cause of stress incontinence is weak pelvic floor muscles, weak sphincter muscle. Weak pelvic floor muscles are known as pelvic floor relaxation, meaning that you do not get good support for the bladder and the sphincter, and that when you cough or laugh or sneeze, the bladder and the sphincter move out of position, allowing leakage. We're going to come back to that. But I just want you to think, in women, the most common cause of stress incontinence is pelvic floor and sphincter weakness. In men, the most common cause of stress incontinence is radical prostatectomy. Go back to the fact that the voluntary sphincter, the striated sphincter, is right below the prostate gland. So if you have a male who requires removal of the prostate gland and the prostatic urethra, there's very likely to be some degree of swelling and trauma to the voluntary sphincter muscle. Typically, it's temporary. Most men recover continence within weeks to a few months. But we do know that pelvic muscle exercises can be very helpful in restoring continence, and we know that some men do have persistent problems. And then for both men and women, if you have direct damage to the sphincter, or if you sustain denervation of the sphincter because of pelvic surgery, because of pelvic trauma, because of a neurologic lesion, that means that the sphincter is not going to work normally, and that person is at risk for leakage. So in women, the most common cause of stress incontinence, pelvic floor weakness, sphincter weakness. In men, the most common cause, prostatectomy. But remember that direct damage or denervation can be a causative or a contributing factor for both men and women. Okay, now we're going to talk about each one of those. So first we're going to talk about pelvic floor weakness in women. I want to go over normal function because, you know, people go through their day, they cough, they laugh, they sneeze, they lift, they jump, they run, they pick up kids, all kinds of things. And most of the time they do not leak. So how is that continence provided and maintained? Well, here's what normally happens. When you cough or you laugh or you lift or you sneeze, you're going to get sphincter contraction, both that guarding reflex, which is reflex activity, and voluntary contraction of the sphincter. And when the sphincter contracts, it closes around the urethra and significantly increases urethral resistance. Also, when you contract the pelvic floor, you get that lift. So the pelvic floor muscles give a lift that holds the bladder and the sphincter in position. As long as the bladder and sphincter are in position, the sphincter functions optimally, and you get optimal urethral closure and urethral resistance. So with normal function, the fact that bladder pressure rises is not an issue because the sphincter compensates. It closes around the urethra, increases urethral resistance, and the pelvic floor holds everything in position. Here's what happens with pelvic floor weakness. The muscles are okay at rest. So as long as I'm standing, sitting, I've got enough resistance because bladder pressures are low. But when I call for laugh or sneeze and my abdominal pressure goes up, it pushes on the bladder and increases bladder pressure. And in that situation, what happens, downward pressure against the bladder pushes the bladder and the urethra out of position. Once you push the bladder and the urethra out of position, you've placed the sphincter in a stretch position where it's trying to stretch and reach around the urethra. And you're going to get compromised sphincter function. In addition, remember that not only do you have pelvic floor weakness, but you also have weakness of the sphincter muscle itself. So in women who have pelvic floor relaxation, two things happen. The sphincter doesn't contract as strongly as it should, and the sphincter is not maintained in position. Everything drops out of position, and that further contributes to leakage. So what can we do about it? We can strengthen the muscles. It is a muscle. It's a skeletal muscle. Just like you can strengthen your abdominal muscles, you can strengthen your quadriceps, you can strengthen your gluteals, your triceps, you can strengthen your pelvic floor muscles. So exercise programs, Kegel exercises, pelvic floor muscle exercises, that's the #1 treatment strategy for weak pelvic floor. You can also consider surgery, which can be used to help hold the urethra in position, hold the sphincter in position, which does improve its function. But even if you do surgery to stabilize everything, you still should be teaching that patient pelvic muscle exercises so that not only is the muscle held in position, but it's also stronger and is able to generate greater contractile force. What about post-prostatectomy stress incontinence? Well, we've already said that most of the time it's temporary. Most of the time the incontinence is caused by some degree of swelling and trauma to that voluntary sphincter mechanism, and of course that subsides progressively in the first few weeks after surgery. Most centers are now teaching men pelvic floor muscle exercises to enhance the rate at which continence is restored. A lot of centers are teaching men preoperatively so that they already know how to do those sphincter exercises before they even have surgery. There are a few men who do have persistent problems with post-prostatectomy incontinence. They may eventually require surgery to provide compression to the urethra. The other thing you have to realize is when they do a prostatectomy, they actually resect the prostatic urethra. So this whole area of the urethra and the surrounding prostate gland are removed. They mobilize the distal urethra and bring it up and anastomose it to the bladder neck. So in addition to the potential for damage to the sphincter, you also get the potential for scar tissue formation. And if you get significant scar tissue formation right here at the anastomosis, that can interfere with emptying as well. It can cause a degree of outlet obstruction. So we really need to follow our patients post-prostatectomy to make sure that #1, they're emptying normally, and number 2, that they are not having problems with stress incontinence. Okay, and then the third reason for stress incontinence is direct damage or denervation to the sphincter muscle, which could be caused by major pelvic trauma, recurrent surgical procedures in the pelvis, most commonly by neurologic lesions, and occasionally by long-term use of urethral catheters that just destroys the elasticity and the contractility of the urethra. What happens when you get direct damage or denervation is that the urethra loses its contractility, it loses its ability to collapse and to maintain that closed position, and instead it starts acting like a lead pipe. So it never actually closes. It never provides adequate resistance. People who have this type of incontinence, if they have stress incontinence because of damage or denervation to the sphincter, most of them have very high volume leakage, to the point that if they just stand up, they're likely to leak. This type of damage does not respond well to exercise, because if you have primary damage or denervation to the sphincter, that sphincter is no longer contractile, and so exercises are not going to be effective. Most of the time, treatment requires surgery. We'll talk more about this when we talk about treatment, but there are some surgical procedures that literally compress the urethra, mechanically compress the urethra. That's probably what this patient would need. Who's at risk for stress incontinence? Well, aging's a risk factor, partially because of the effects of menopause. I didn't put it up there, but I should have. Female gender is actually the #1 risk factor for stress incontinence, which makes sense, because who is it that's going to have pelvic floor relaxation? It's women. So start with female gender. Add the impact of aging, so you get gradual weakening of the muscles, especially if they're not exercised. If this woman has also had traumatic vaginal deliveries or multiple vaginal deliveries, that's another risk factor, because babies create a lot of stress on the pelvic floor. They're very cute, but they're not good for the pelvic floor. And so you think about, especially a woman who has a prolonged second stage of labor where the baby's head is down on the pelvic floor for a long time, that can cause a lot of stretch and injury to the ligaments, to the muscles of the pelvic floor. So traumatic vaginal deliveries are considered a risk factor, multiple vaginal deliveries. Having said that, we need a lot more data as to the exact impact of vaginal delivery on pelvic floor health long term. We don't have good data that says C-section is protective. So if you're young and haven't finished having babies, don't run out there and ask for a C-section. That might not protect you. And of course, we know there's other issues related to C-section. So we have a lot left to learn about the exact impact. We do know that there's a correlation between vaginal deliveries and stress incontinence, but so far our data suggests that it's more complex than just the delivery, that maybe it's partially the effects of pregnancy as well as delivery. So we know it plays a role, we don't know exactly how. Hysterectomy can be a risk factor, because hysterectomy involves work right around the nerve pathways that maintain continence, that innervate the sphincter. And if there's any damage to those nerves, that increases the risk of incontinence. So doesn't mean that everyone who has a hysterectomy is very likely to be incontinent. It just means that's another thing to screen for and to think about. Chronic straining at stool. And you can see how this would contribute, because a woman who's chronically constipated and constantly or chronically straining to push stool out is getting a lot of downward pressure on that pelvic floor and weakening the pelvic floor over time. Very long-term use of an indwelling catheter. Now, we're not talking days and weeks, we're talking months to years. So you know that in the past we have frequently used indwelling catheters for management of a wide range of conditions, from neurologic conditions to intractable incontinence. And if you constantly have a catheter in the urethra, especially if it's a larger catheter, what are you doing? You're stretching the urethra. And you're destroying the elastic fibers in the urethral wall, and you're compromising the muscles in the urethral wall. So days to weeks, very safe. But once you move into months to years, you have to think about the fact that you could be destroying the urethra, and you could be taking away that patient's chance for normal function. Pelvic trauma, surgery, we've talked about that. How does that have a negative impact? By causing damage to the nerves that innervate the sphincter. Prostatectomy we've talked about, and neurologic lesions. Okay, so let's talk about how do you diagnose stress incontinence. You think that's what the patient has. She's female, so that puts her in the range. And she tells you she's not leaking when she's just walking around and doing things, that her leakage primarily occurs when she gets on the trampoline with her kids, or she goes to exercise class, or she picks up her 3-year-old, whatever. So you're thinking, that sounds just like stress incontinence. And indeed, patient history is the number one way to diagnose stress incontinence. So patient history, absolutely critical. There are some tests that can be done during the exam. They're not widely used. They're described in your materials. Paper towel test is as simple as taking a folded paper towel, having the woman stand up, hold the paper towel between her legs, cough forcefully, and then you look to see is there leakage. Now, all that can do is confirm leakage with activity. It doesn't tell you the specifics about how severe it is, but it does confirm leakage with activity. You can then have her repeat that test, but tell her this time, before you cough, I want you to tighten your muscles like you're trying not to pass gas. And you're looking to see is there any reduction in the amount of leakage. If so, it strongly suggests that she's going to do well with pelvic muscle exercises. Q-tip test is not widely used, but I have it in here. We have it in here because it's still sometimes asked on the certification exam. So the whole concept of the Q-tip test was that you took a lubricated sterile Q-tip, you put it through the urethra up to the level of the bladder. And then you had the patient forcefully cough. And you look to see if the angle of the Q-tip came up, because if the bladder tips down, the Q-tip will come up. First of all, there is no data that says that that's really a valid test, that it accurately measures the degree to which the urethra moves out of position. Secondly, it's extremely uncomfortable. Would you lie still on a table if you saw somebody coming at you with a lubricated Q-tip? I don't think so. If you want to see what happens, if you want to get an indirect measure as to how much the bladder and the urethra shift out of position, it would be better to take an OB swab and put it into the vagina, because you'd get the same effect. Or if you really want to do the Q-tip test, put in a female catheter. Just put in a female catheter and see what happens, because that's much softer than the Q-tip. And then pad weight testing is sometimes done as part of research studies where you measure the weight of pads before they're worn, so you get their dry weight. Then you have the patient wear the pad for a defined period of time while carrying out certain activities. And then you reweigh the pad to see how much urine she lost. So it's a great way to measure the impact of a treatment program, but it's not routinely used for diagnosis. Notice in bold, if you want a definitive diagnosis of sphincter dysfunction, you have to do urodynamic studies, which involves filling the bladder, putting in a catheter that is pressure sensitive, using that pressure sensitive catheter, pulling it through the urethra, and the whole time you're pulling it through the urethra, you're measuring pressures. So when it says urethral pressure profile, it literally generates a profile of how much pressure is generated by the urethra. And typically, so you're pulling it through, the highest pressures are generated right here at the level of the voluntary sphincter. So usually your urethral pressure profile looks like this. There's another test, abdominal leak point pressure, where you have the patient gradually bear down and you record the point at which leakage occurs. These tests are not typically used in primary care, but they are sometimes used if a patient is considering surgery and you need to prove that there's significant stress incontinence that might be mitigated by a surgical procedure. Overview of treatment. When you think stress incontinence, I hope you think muscle weakness, because that is the most common cause of stress incontinence. Pelvic floor muscle weakness, sphincter muscle weakness. And I hope that you then think pelvic muscle exercises. Weak muscles respond to exercise programs. And we're going to go over those in detail when we talk about treatment. That's in bold. They've used electrical stimulation. We don't have great data on electrical stimulation, so we're not going to talk a lot about that. We've already said estrogen can be beneficial in postmenopausal women and restoring the health of the urethral mucosa, making it sticky again, improving the thickness of that vascular bundle, submucosal vascular bundle. But sympathomimetic drugs, theoretically, they could help tighten the sphincter, but we don't have any medications that are approved for use with stress incontinence other than topical estrogen. We will talk about using pessaries to provide support for the urethra and the bladder neck and to help hold the urethra and bladder neck in position. Not widely used, but an option. We will talk about the availability of urethral inserts for women and penile clamps for men. And yes, I know that sounds archaic, but they are still sometimes used and successfully used, so we will come back to that. But the other treatment option that's in bold, pelvic muscle exercises in bold, surgery in bold. A variety of surgical procedures available for individuals with stress incontinence. Most of them simply stabilize the urethra in position in order to optimize sphincter function. But some of them actively compress the urethra to actively increase urethral resistance. We will talk about the different types of surgical interventions in detail under treatment. Right now, I want you to focus on this and this just as options. What are the options? Exercises to strengthen the muscles, surgery to either stabilize the urethra, hold it in position, or to actively compress the urethra in patients who have very severe stress incontinence with very limited urethral resistance. The second very common type of incontinence is overactive bladder, also known as urge incontinence. If you understand stress incontinence and urge incontinence, you can help a whole lot of people, because about 90% of people who come to clinic with bladder complaints have either stress incontinence, urge incontinence, or mixed stress urge. So focus your study on stress and urge. I think everybody can relate to this. Overactive bladder, what does that say to you? Well, if you have an overactive child, why do we call them overactive? Because they can't sit still, right? They're up. They're doing this, they're doing that, they're doing the other. They can't finish their meal, they can't finish anything. What would an overactive bladder do? overreact to small amounts of urine in the bladder. So even small amounts of urine would be interpreted as, I've got to go. You know that TV commercial, that gotta go woman? She has overactive bladder. So with overactive bladder, the bladder feels and acts full at low volumes. You can have wet or dry OAB. Wet OAB means that in addition to having frequency and urgency, running to the bathroom all the time, sometimes you don't make it. Sometimes you have leakage. Dry OAB means you have that urgency, you have that frequency, but you're not leaking. It follows gender lines, not surprisingly. Wet OAB, typically found among women. Dry OAB, typically found among men. Look at the problem. It's not the sphincter, it's the bladder. The bladder is not stretching and storing. Instead, small amounts trigger overactivity at the level of the bladder. And what's the bladder saying to you? I've got to go, I've got to go, you've got to take me to the bathroom. I'm full, I'm full, I'm full. Even though there's only maybe 100 cc's in the bladder. Why? You know what? We really don't know. We still don't know. In some patients, it seems to be cerebrocortical lesions or disease, so we know that OAB is common in patients who have had stroke, so that they've lost some of that ability to synthesize data and to make appropriate decisions and to override the PAG and the Pontine Micturition Center. We know it's more common in patients with Parkinson's. Even though we don't understand all of the details as to why, we know that cerebrocortical lesions can interfere with the ability to control the bladder. But most patients who have OAB haven't had a stroke, don't have Parkinson's, and have no obvious cerebrocortical lesions. So then what's going on? Well, one theory is that the lining of the bladder that normally sends some signals about bladder filling, that there's something going wrong there, and so that sensory signaling is inappropriately, sensitive, so that you're signaling the brain that the bladder's full and it's really not. But we don't know how to measure that, we don't know how to confirm that, and we certainly don't know how to treat that. It's just a theory, it's a hypothesis, that maybe that's part of the problem, that the messages to the brain are incorrect. The other theory is that, well, maybe it's not so much the messages to the brain, maybe it's the bladder itself, maybe it's the detrusor muscle, maybe it's inappropriately twitchy, and that's the problem. Well, you know, anytime that you have hypotheses and theories, it means you don't really know. And that's where we're to. We don't really know what causes it. We know a lot more about recognizing it and treating it than we do about the specific causative factors at this point in time. But we can recognize it. Patients can recognize it. We can recognize it. Urgency, frequency, nocturia. Those are the three hallmark indicators of overactive bladder. If you have all three of those together, that carries greater than 90% positive predictive value for a diagnosis of OAB. So let's talk about each of these. Urgency. Well, how do I know you have pathologic urgency? Because we all have urgency sometimes. We all have stood up from our desk and thought, ooh, I hope I make it. We've all said, I can't do anything else till I go to the bathroom. I'm about to die to go. So what's the difference in that and pathologic urgency? Here's the difference. If you got up from the nurse's station where you were documenting, and you're like, I can't do anything else until I go to the bathroom, but you're walking down the hall and somebody's falling out of bed, your bladder goes on hold and you go take care of the patient. Or if you walk by somebody's room and both the monitor and the patient look like they're flatlined, you stop and call a code. And your bladder goes on hold, and then a few minutes later you're like, oh, that's right, I had to go to the bathroom. If you have pathologic urgency, you have the sense that you cannot stop. You cannot put your bladder on hold. If someone codes in front of you, you're probably thinking you've got 3 to 5 minutes and I can pee really fast, because you just don't feel like you can wait. So pathologic urgency is the sense that you cannot delay voiding. Frequency. Now there's 2 ways to look at frequency. Sometimes they say if you void more than 8 times in 24 hours. Here's the problem with that. Most of us do not count our voids. Like if I asked you how many times did you void yesterday, I hope you couldn't tell me. Because if you can, I'm kind of worried, you know? So instead of looking at number of voids in 24 hours, more commonly people ask a patient, can you sit through a 2-hour movie? On average, can you sit through a 2-hour movie or a 2-hour TV program? Can you sit through a 1-hour program? How long can you go on average without urinating? Of course, we know it's affected by how much you had to drink and stuff like that, but on average, an adult with normal bladder capacity should be able to go at least 2 hours and frequently 3. So that might be a better way to get at frequency than asking a patient how many times they void. The other way is to get a bladder chart, and we'll come back to that. Because they're voiding so often, typically they have low voided volumes, so each void is typically less than 100, 120 cc's. Because their bladder doesn't hold much, they don't make it through the night. They get up multiple times at night. Other symptoms: leaking on the way to the bathroom, leaking in response to common stimuli, for example, running water. Key in the lock syndrome. Some of you probably relate to key in the lock syndrome. So you're driving home, you think you're going to make it, you pull into your driveway or your garage, turn off the car, get out. You're okay, you're okay, you're okay. You get to the front door, you put the key in the lock, and all of a sudden you have intense urgency. There's a related syndrome where you know you have to go, you're going to the bathroom, you walk into the bathroom, and as soon as you see the bathroom, you have intense urgency. So that is your brain responding on a subconscious level to signals, okay? Putting your key in the lock. Oh, I'm home. Yes, but I'm not in the bathroom yet. Or I walked into the bathroom, I'm here. That is a hallmark indicator of overactive bladder. You hear that pretty consistently from people who have overactive bladder, so you can ask them about that. Leakage with intercourse. Not everyone has this, but people who do frequently say is the most bothersome symptom. That if you could get rid of that, they could probably handle everything else. Toilet mapping, meaning I know where every bathroom is on my way to work, where I usually shop. I've consciously mapped the toilets because I know I'm going to need them. Now remember that the elderly may have combination problems, so they may have this syndrome of overactive bladder, frequency, urgency, etc. But they might also have impaired contractility. So they might come in complaining of running to the bathroom all the time, going little bits, having to get up at night, sometimes leaking on the way. You're thinking classic overactive bladder. But if you take it a step further and you ask them, are you pretty confident that you empty your bladder every time you go? They might say, well, I'm not sure, I think I do, I guess I do, I don't know. And if you do a bladder scan, you frequently find that they have elevated PVRs. I'm just going to say this now, we'll say it again later. If you have a combination problem with emptying and with storage, so you're leaking but you're not emptying completely, you always start with the emptying problem. If I can improve your emptying ability, I automatically reduce your frequency. Because if you went to the bathroom with 300 and you voided 100 and you left with 200, you were 2/3 of the way full when you left. If I can get you down to 50 residual instead of 200 residual, I give you a lot more storage time. So anytime you have combination problems, always start with the emptying problem first. What about diagnostics for overactive bladder and urge incontinence? Well, usually we diagnose overactive bladder on those clinical symptoms. If you have that triad of frequency, urgency, and nocturia, we've already said, very high predictive value. Yes, you're going to do a urinalysis if indicated to rule out infection, to rule out leukosuria, to rule out hematuria. You're going to do a post-void residual if you have any reason to be concerned about retention. But objective diagnosis of overactive bladder itself requires urodynamic studies, requires you to put that pressure-sensitive catheter in the bladder, hook it to a computer screen, to gradually fill the bladder, to determine how much the bladder can hold, at what point the person senses intense urgency, and to see whether or not there are any uncontrolled, inappropriate bladder contractions. We'll come back to that. Go back to this. For both stress and urge, diagnosis is primarily based on patient reports and backed up with physical exam. We'll be talking about physical exam in our next class. Okay, what can I do about it? You come in, you have classic presentation of overactive bladder. I did a urinalysis, it was negative. I did a PVR, it was within normal limits. So I want to treat you. That's what you came in for. Please help me. Help me get my bladder under control. So I'm going to start out. I'm going to say, let's talk about what you drink. Well, I drink coffee, 2 or 3 cups of coffee for breakfast. I drink a Diet Coke in the morning. I drink tea for lunch. I drink another Diet Coke in the afternoon. And I drink tea for dinner. And then sometimes I have coffee before I go to bed. Sometimes I have wine. Okay, well, there's a lot of potential irritants there. So I might want to talk to you about, the data here is limited, but we have some information that suggests that caffeine and carbonation and aspartame and nicotine can irritate the bladder and make it feel and act full at lower volumes. Would you be willing to do a trial for 2 weeks where you reduced your intake? And here's specifically what I'm saying. Would you be willing to have 1 cup of regular coffee and 1 cup of decaf in the morning? And would you be willing to substitute for your Diet Coke an herbal tea or a flavored water? Let's leave your tea at lunch. Let's substitute for your Diet Coke in the afternoon. Let's leave your tea at dinner. Let's substitute for your coffee at bedtime, and let's see if that makes a difference. I would talk to them about that. I would make absolutely sure that their bowel was cleaned out and functioning normally, that they were having regular bowel movements, that there was no retained stool in the rectum to further add to bladder irritability. Fluid management, we talk to people, if you're having problems with urgency and frequency, you need to avoid bolus drinking. Don't gulp 12 ounces or 16 ounces. You need to drink along. So take that 12 ounces and drink it over the course of an hour instead of all at once. Weight loss has been shown to be beneficial in patients who are obese if they're willing to do that. Environmental modifications to make it easier for the patient to get to the bathroom, to get their clothing out of the way. But look at the 2 things that are in bold. Those are the primary treatment strategies for overactive bladder. Bladder retraining, pelvic muscle exercises. What is that? It's teaching the patient to use their pelvic muscles to control bladder function and to use other urge inhibition strategies like deep breathing and standing still. So you think what people typically do when they have intense urgency, they rush off to the bathroom So now they're bouncing their bladder, which is already very twitchy. Not a good idea. Much better to stand still or sit down. If you do 5 rapid contractions of your pelvic floor muscles, it sends a message back to the bladder that causes relaxation. So pelvic muscle contraction can be used to control bladder contractility. And deep breathing can also be used to reduce the sensation of urgency. So standing still, doing pelvic muscle contractions, doing deep breathing. We'll come back to that. And for overactive bladder, yes, we have a number of medications that we can use. That whole classification of anticholinergic drugs, like Ditropan, like Detrol. Within the big category of anticholinergics, antimuscarinics are particularly beneficial because the specific cholinergic receptors on the bladder wall that cause bladder contraction are muscarinic receptors. So if you can use one of the new antimuscarinics, like Vesicare is one, that can be extremely helpful. So yes, we have medications that can help here. And there's another set of interventions that's used only for refractory OAB, and that's neuromodulation therapy. And we'll come back to that. We're not going to talk about that today. Okay, so spend a lot of time making sure you understand stress and urge, and mixed stress and urge, which is nothing more than what it says, where you have to use a combination of management strategies for stress and management strategies for urge, because the patient reports leakage, sometimes associated with urgency and sometimes associated with activity. Functional incontinence, which is also sometimes known as incontinence caused by functional factors, because we like to use more words, I guess, is very common in the long-term care population. Very common among the elderly who have any degree of dementia. Functional incontinence is characterized by normal bladder function, normal sphincter function, fairly normal voiding patterns. But they're incontinent. And they're incontinent because of cognitive impairment. That's the most common reason. Some of them are incontinent because of severe mobility impairment. So here's what happens. My bladder fills. A message goes to my brain, processed through the midbrain. It's supposed to go to the cortex to say, bladder's full, but this is what's going on. The problem is, when it gets to the cortex, what can the cortex do with it? Nothing. That report might as well be written in Greek. The cortex has lost the ability to appropriately interpret messages sent by the bladder. So the message goes, but the message is not interpreted. The cortex does not take appropriate action. It doesn't send the message back down, stop voiding. It takes no action at all, and the pontine micturition center takes over. Opens the sphincters, contracts the bladder. So dementia, a very common reason for incontinence in the elderly. The other reason for incontinence is severe mobility impairment, where I just cannot get from here to there in a timely manner. And by the time I get there, I've already had a leakage episode. So dementia or severe immobility. How do I make a diagnosis? Is there one little test I can do? No. But I can use clinical observation. I can quantify their cognitive impairment using one of the cognitive assessment tools like the Mini-Mental Status Exam or the clock drawing test or whatever. I can certainly quantify their mobility impairment. So I have, on the one hand, observed voiding patterns, and I have, on the other hand, documented evidence of severe cognitive impairment or severe mobility impairment. I also have to remember to screen for reversible factors and to correct them. So looking at clinical signs and symptoms, we've already talked about it. It's a patient who's incontinent at regular intervals. Most of the time, the patient seems unaware. Sometimes they'll be a little bit agitated before an incontinent episode. It's almost like they know something's going on, but they can't figure out what. But most of the time, they seem unaware. You, as we have already said, document cognitive status, document mobility status, document their overall functional status, level of frailty, and their ability to toilet. Can they toilet with assistance? Can they toilet with reminders? How much assistance does it take? That kind of thing. In the long-term care setting, a standard element of assessment is a 3-day voiding trial to see what happens when I take you to the bathroom on a regular schedule and prompt you to void. What percentage of the time are you able to respond appropriately to that prompt? What percentage of the time are you able to void in the commode? If you're able to respond 50% of the time, 60% of the time, then a voiding program will probably be helpful for you. And the bottom line, there's 2 options I have. I can put you on a toileting program where I take you to the bathroom, prompt you to void. I would still need to put you in absorptive products because a toileting program is not going to keep you 100% dry. It's still worthwhile. If it significantly reduces incontinent episodes, it's better for your skin. It reduces the risk of UTI, reduces the risk of falls, and is better for your overall psychosocial status. If you're unable to respond to a toileting program, then I have to manage you with absorptive products. So we've talked about incontinence. We've talked about problems on the storage side of the voiding cycles. We've talked about stress incontinence, where the whole issue is the sphincter doesn't do its job and allows leakage. We've talked about overactive bladder urge incontinence, where the bladder is not functioning normally and it feels and acts full at low volumes. We've talked about functional impairment, where the problem really isn't the bladder or the sphincter. The problem is the patient can't get to the bathroom in time, or the patient doesn't recognize the need to get up and go to the bathroom because of dementia. Now we're going to look at the other side. We're going to look at the inability to empty effectively, which we all know is retention, and which is officially called voiding dysfunction. You know what it is. It's incomplete bladder empty. It results in a constant state of fullness. Some patients leak, so they might have leakage, they might not have leakage. But the defining characteristic is incomplete empty, resulting in a constant state of fullness. Now, you can have acute urinary retention or chronic. Acute urinary retention is very painful. It is sudden onset of the inability to void. The bladder distends rapidly. It's acutely painful in any patient who has intact sensation. It can be precipitated, and commonly is precipitated, by surgery, by medications. Sometimes it's spontaneous. If it just occurs spontaneously, it's most likely to be a patient who has significant prostatic hypertrophy. But acute retention occurs suddenly, causes acute pain, has to be treated urgently, and we'll come back to that. Most of the patients you and I deal with have chronic urinary retention. These are patients who they void, but they don't empty completely. They have high post-void residuals, defined as at least 300 and sometimes higher. Most of the time it's not painful because the bladder has stretched over time, so there's a gradual increase in bladder capacity. So the patient may be aware that they don't feel like they're emptying completely, but they do not typically complain of pain. Now this is important. Chronic urinary retention can either be high pressure retention or low pressure retention. It depends on the causative factor. If urine retention because there's outlet obstruction, like if you have a very enlarged prostate gland and it's closing off the urethral outlet and the bladder's working really hard to try to force urine through there, it's not succeeding very well, but it's working really hard, then you've got very high bladder pressures. Those high bladder pressures, remember, go backwards and impact on the kidneys. So if I have very high bladder pressures, what happens to the ability to deliver urine to the bladder? It's impaired because the bladder pressure is higher than the ureteral pressure. So if I have high bladder pressures associated with an outlet obstruction, it's going to create back pressure on the kidneys. It's going to place that patient at very high risk for renal damage. That patient is going to require urgent intervention. In contrast, if I have a patient who has long-standing diabetes and their bladder has just lost contractility, so it's stretched out, stretched out, stretched out. Now their bladder holds 900 cc's. And they just maybe void 100 at a time. But because their bladder is very stretchy, the bladder pressures remain low. In that case, there's minimal risk of renal damage. Treatment is not nearly so urgent. Treatment is determined by patient concerns, patient goals, and also whether or not they're developing recurrent UTIs. So you know that sometimes a patient in retention develops recurrent UTIs. Certainly if that was happening, they'd require urgent treatment. So what I want you to take away from this is that any patient in acute retention requires urgent intervention. And they always get it because they're in screaming pain. So I'm not worried about them. They're going to get treated. I mean, I'm worried about them, but I'm not worried about them getting missed because they won't get missed. They're in pain. This is the patient who could get missed. The patient with chronic retention, they're not in pain, but their bladder's working very hard on a continual basis to try to force urine through that obstructed outlet. That means they have persistent high pressures within the bladder. Those high pressures interfere with urine delivery and create significant risk of upper tract renal damage. So anytime we have a patient in retention, we have to do appropriate screening, we have to do the workup, we have to determine, is it high pressure, is it low pressure, does it require treatment, or is treatment dependent on patient goals? Okay, what causes retention, what causes voiding dysfunction? Basically two things. Either something is in the way. The bladder's functioning normally, now it's working extra hard because it's trying to force urine past the outlet. BPH, the most common reason. But in women can also get high pressure retention, and in women it's most likely to be due to pelvic organ prolapse or a major cystocele, so that it's very hard to get urine out. The other big reason is you've got a very weak detrusor. The bladder's just not contracting appropriately, and that could be because of long-standing diabetes, because of a neurologic lesion, because of aging. Now, the signs and symptoms, again, acute urinary retention is rapidly progressive pain and abdominal distension. I want you to focus more on chronic retention. I want you to notice frequency, urgency. Well, that goes with retention because they never empty, but it also goes with overactive bladder, so it's not definitive. Small voided volumes, same thing, could be either retention or overactive bladder. Nocturia, same thing. With retention, The reason you have frequency, small voided volumes and nocturia, is because you never empty. With overactive bladder, you have it because your bladder is unable to store normal volumes. So it produces the same picture for different reasons. I want you to focus on the signs and symptoms that are unique to retention. Feelings of incomplete empty. A very important screening question for every patient. When you urinate, do you feel as if you empty? We'll come back to that in the next class. What's your stream like? You know, do you have a constant flow of urine until you're done, or is it intermittent? Is it a strong stream or a weak stream? If it's weak or intermittent, that suggests problems with empty. Elevated PVR. If I have any reason at all to suspect retention, I should be doing post-void residual. And suprapubic tenderness. So how do I diagnose? Remember, acute urinary retention always gets diagnosed. Our big challenge is to distinguish between high pressure chronic retention and low pressure chronic retention. Is there an outlet obstruction and the bladder is working really hard and creating back pressure on the kidneys? High pressure? Or do I have a very weak, stretched out bladder muscle? Low pressure, not really a threat to the kidneys. So I'm going to get their history, of course. I want to know, have you ever been diagnosed with prostate enlargement if you're male? If you're female, have you ever been diagnosed with pelvic organ prolapse? I want to do a urinalysis because I have to know whether or not there's any signs of infection. I want to know if you have a history of infection. I want to do some serum studies like BUN and creatinine to rule out any evidence of renal damage. If I have a patient and I'm concerned about renal damage because they have a clinical picture that's consistent with high pressure chronic retention, or if their serum studies indicate renal damage, I'm going to do a renal ultrasound. I'm looking for hydronephrosis. And I should have put this in bold because these are the things that always get done. You're always doing a post-void residual if you have any reason at all to suspect voiding dysfunction retention. You're doing a PVR. If you have access to a Uroflow, which is a special commode that actually produces a printout of the urinary stream, you would do that. We'll talk more about that in the class on assessment. And a pressure flow study. What is that? We're back to urodynamics, where you place a pressure-sensitive catheter in the bladder and hook it up to a computer. You gradually fill the bladder, so you determine how much the bladder can hold and what pressures are generated within the bladder. And then you have the patient void still with that pressure-sensitive catheter in the bladder, and that tells you, well, what's the contractile pressure? So now you know filling pressure. What's the contractile pressure? And how does it correlate with flow rate? So if you have abnormally high filling pressure and contractile pressure, you've got a high pressure retention state, and that requires treatment. So how do you treat? Well, acute retention is obvious, and we all know this. We've all been, in a patient's room or in the emergency room when a patient came in with acute retention. Yes, how fast can you get a catheter in them? So you get the catheter in, you drain the bladder. Very helpful to pay attention to how much urine you get within the first 10 to 15 minutes of drainage. If you get more than 1,000, it suggests that the patient had an underlying chronic retention and a superimposed acute retention. The first thing, urgent catheterization. Manage any obstructive lesions. So do they have an enlarged prostate? You've got to deal with that. Or you can deal with it pharmacologically with medications, or you can do surgery. But clearly the prostate's causing a major problem. You have to deal with that. And then once the bladder's been decompressed and any obstructive lesions have been eliminated, then you can remove the catheter and allow them to try voiding. It's called a trial of voiding or a trial without catheterization to see is bladder function normal enough to empty? Again, most of our patients fall into the chronic retention range. Equally important for these patients, eliminate any obstructing lesions, because nothing's going to get better till I do that. So I've got to deal with that. Clean intermittent catheterization, the #1 treatment, especially for patients who have low pressure chronic retention, that patient with the big stretched out floppy bladder that's not contracting well at all because of diabetes, because of multiple sclerosis, whatever. How am I going to get urine out of the bladder? We don't have medications that will make the bladder contract more effectively, but we can pass a catheter in, drain it out, take it out, wait 3 to 4, 5 hours, put it back in, drain out the urine, take it out. So clean intermittent catheterization, a very important tool that we have for managing incomplete empty, especially when the reason for incomplete empty is a very weak detrusor. We don't have anything that will fix that, but we can compensate with in and out catheterization. What about double voiding? What is that? When would we use that? That can be helpful for patients with mild to moderate retention. It's just voiding, waiting 1 to 2 minutes, and again initiating voiding. The thinking being, if you go with 400, first void you eliminate 150, so now you're down to 250. If you wait a couple of minutes and you again initiate a void and you can void 75 more, now you're down to 175. So it helps you reduce the rate at which the bladder overdistends and hopefully keep the patient out of trouble. Indwelling catheter, last resort. We really don't want to go there. So if the reason they're not emptying is because there's something obstructing the outlet, we want to remove the obstructing lesion, surgically or via medications. If the problem is that the bladder just is not contracting effectively because of a neurologic lesion or because of long-standing diabetes, clean intermittent catheterization, the best treatment option if the patient's able to do that. And we'll come back to that in our discussion of treatment. Extraurethral incontinence, what did I say? We weren't really going to spend time on it. You can see we're really not going to spend time on it. If you have extraurethral incontinence, you're leaking because you have an ectopic ureter that bypasses the sphincter, or you have a fistula from the bladder to the vagina or the bladder to the skin. The only thing that's going to fix either one of those situations is surgery, and until you can do surgery, you're going to use absorptive products. That's all we're going to say about that. So we're down to just a couple of types. We're going to talk about neurogenic, and then we're going to talk about enuresis. Now, neurogenic incontinence is the most complex type of incontinence. It's the one that is hardest for people to understand usually, but it's also the one you're least likely to encounter. So make this one last on your list. Make sure you understand stress. All kinds of people have stress incontinence. Make sure you understand urge, overactive bladder. Make sure you understand functional, and that you get the basics between acute retention, chronic retention, and between high pressure and low pressure. If you know those and you don't get neurogenic, that's okay, because you can refer those patients. I'm going to go over it. I do want you to get it, but I want you to know this is not the hill to die on unless you're going to work in a rehab center or a neuro unit. Okay, so neurogenic incontinence. What's the pathology? What's causing the problem? Well, you have a neurologic lesion. It might be at the level of the brain. It might be at the level of the spinal cord. It might be at the level of a peripheral nerve. Bottom line, if you have a neurologic lesion somewhere at the cortex or between the cortex and the bladder and sphincter, then you've got impaired communication. So you're not getting messages back and forth reliably from the control centers in the head to the bladder and sphincter in the pelvis. End result, you lose some degree of voluntary bladder control. We are not going to ask you this, so I'm just mentioning it because if you end up in a neurologic setting, you're going to hear this terminology. Sometimes they'll further classify neurogenic lesions as either upper motor neuron lesions or lower motor neuron lesions. Upper motor neuron lesions are patients who typically have frequency and urgency but no voluntary control. It means that it involves the brain or the upper cord, and you lose voluntary control and typically have frequency and urgency. Lower motor neuron lesions are caused by sacral cord level lesions, and they cause a non-contractile bladder that becomes massively distended with just overflow leakage. Again, don't worry about upper motor neuron, lower motor neuron. That's not what we're going to test you on. When you're talking about neurogenic incontinence, it helps to just break it down. Where is the problem? If you understand where the problem is, then you can go back to the basics of voiding physiology and you can figure out what happens. So if you have a cerebrocortical lesion, CNS lesion, what did we say the cortex gave you? It gives you social continence. It gives you the ability to decide when and where to void. If you have a CNS lesion, what do you lose? Social continence. That ability to reliably delay voiding until it's socially appropriate and convenient. What if you have a lesion somewhere above the sacral cord where you have that reflex arc, so somewhere above the sacral cord, between there and the brain? You're going to have no awareness of bladder filling because messages from the bladder do not get up to the brain because there's a lesion in here. So you won't know when your bladder's full, or you'll have diminished awareness. You will not have good voluntary control because voluntary control starts here and comes down. You will be able to empty the bladder by the reflex arc because the reflex arc remains intact. So sensory input from the bladder comes over, kicks off the parasympathetic nerve, the bladder contracts. But you may also have bladder sphincter dyssynergia because all of that coordination you get from the Pontine Micturition Center, you've lost it. So you don't have any way to reliably open the sphincters before the bladder contracts. And a lot of patients who have suprasacral cord lesions have bladder sphincter dyssynergia. What does that mean? It means they're working against each other. Instead of working in synergy, they're working against each other. So the bladder's contracting and trying to force urine out, and the sphincter's contracting and holding it in. That's a huge problem, dyssynergia. We have to find a way to get urine out of the bladder when they have dyssynergia. So suprasacral cord lesions, those are your spinal cord injured patients. Most of them have suprasacral cord lesions. All of your paraplegics, or most of your paraplegics, all of your quadriplegics have suprasacral cord lesions. A lot of your MS patients have suprasacral cord lesions. So very common among your spinal cord injured patients. Sacral cord lesions, very low level lesions. These are your patients who might have a spinal cord injury or MS, but they're ambulatory with braces. However, they have a lot of problems with bladder control. And look what happens here. They have no awareness and no control. It's even more serious than that because you've come beyond this point, you've knocked out the reflex arc. So you cannot voluntarily initiate voiding, and now you've lost the reflex arc as well, so there is nothing to tell the bladder to contract, so it just fills and fills and fills to maximum stretch capacity, and then you overflow dribble, overflow dribble, overflow dribble. Needless to say, they're very high risk for urinary tract infections and eventually for renal damage. So what are the signs and symptoms? Again, it depends on where is the lesion. So if I have a cerebrocortical lesion, if I've had a significant stroke, if I have Parkinson's, I'm going to tell you that I know when I have to go, but that I don't have enough warning, and that I'm going much more often than I did before my stroke, and sometimes I don't make it. And our management is going to come right back to how we manage patients with overactive bladder, because essentially this patient has overactive bladder. What about the patient with a spinal cord injury, T10, L2, S1, C5, C6? They're going to tell you either I don't know when my bladder's full, or I just have this very vague awareness. I have a tingling at the back of my neck. I cannot control voiding. I cannot voluntarily initiate voiding, and I can't stop it. It just happens. If this patient has a lesion between the sacral cord and the brain, he or she is at risk for dyssynergia. I have to do urodynamic testing to rule that out. And then the patient with a very low-level lesion, a sacral cord lesion, again, do you know when you have to go? No. Or I just have vague awareness. Can you initiate voiding? No. Can you stop voiding? No. They probably have visible distension, and when you either cat them for PVR or scan them for PVR, you find a lot of urine in their bladder. But they probably report being frequently wet because of that overflow pattern of voiding. Okay, so how do we diagnose them? Well, we have their history that includes a neurologic diagnosis, which should have been confirmed. So yes, we need to confirm that they've had a stroke, they have Parkinson's, they had a spinal cord injury. Most of the time that's already been done. Here's my point with this slide. Urodynamics, ideally video urodynamics, are essential for a patient with a cord lesion to rule out dyssynergia. So if the patient has that suprasacral cord lesion, I have to do video urodynamics. Really helpful for any patient with a neurologic lesion, but essential for a patient with suprasacral. And we'll come back to that when we discuss assessment and exactly what you get from video urodynamics. But remember, you're going to be filling the bladder with, you're going to be placing a pressure-sensitive catheter in the bladder, hooking it to a computer, filling the bladder with contrast. Then you're going to be tracking how much the bladder can hold, what the filling pressures are, the patient's sensory awareness, and at what point the bladder contracts. When the bladder contracts, you're going to be looking to see, does the sphincter open or does it stay tight? That helps you rule out dyssynergia. How do you manage? Again, it's going to be dependent on the location of the neurologic lesion and the clinical presentation. If I have a patient post-stroke, if I have a patient with Parkinson's who has that overactive bladder presentation, frequency, urgency, nocturia, leakage, I'm going to look at fluid intake. I'm going to look at constipation management, make sure their rectum is cleaned out and that they're having regular bowel movements. I'm going to put them on one of those bladder training programs where I teach them, when you get the urge to go, stand still or sit down. Contract your pelvic floor. Deep breathe. And I'm going to consider anticholinergic, antimuscarinic medications. If I have a patient with a suprasacral cord lesion, most of those patients are wheelchair bound. And most of them are going to be most effectively managed with clean intermittent catheterization. If that patient has dyssynergia, Clean intermittent catheterization is an excellent management plan because when I pass the catheter in, I bypass the sphincter. So CIC replicates normal bladder function. You drain the bladder, you remove the catheter, you allow the bladder to refill, you drain it, you remove the catheter, it refills. If the patient has a very small fibrotic high-pressure bladder, they might require augmentation cystoplasty. That's a procedure where you open the bladder and attach a piece of bowel, typically small bowel, to enlarge the bladder and to reduce contractility. It gives you greater capacity and lower pressures. So some of your cord injured patients need that. What if I have a young guy and he doesn't want to do intermittent catheterization? He'd rather just wear a condom to a leg bag. That's okay as long as I've done my urodynamics and I know that he does not have dyssynergia. If he does have dyssynergia, then I have to try using alpha-adrenergic antagonists to open up the bladder neck. See if I can open up the bladder neck enough so that all the urine flows through and I'm not getting elevated PVRs. Indwelling catheter, last resort. We really do not want to use an indwelling catheter because there's many complications associated with that. You know that, and we'll talk more about that in management. But I certainly could do a urinary diversion if the patient didn't want to do clean intermittent catheterization, they weren't a good candidate for condom drainage, or it's a female. I'm trying to avoid an indwelling catheter. What about urinary diversion? That patient might be able to manage a pouch easier than she could manage urethral catheterization. So that should always be a consideration. And then the last thing we're going to talk about briefly is nocturnal enuresis in children, which is, of course, bedwetting past the age at which nighttime continence is typically obtained. And that's usually 4 to 6. Now, what causes it? There's been a lot of study on this, and the current thinking is that most cases of enuresis are caused by a delay in maturation of some of the neurologic pathways. So it's not cognitive delay, but there are multiple little neurologic pathways that have to undergo maturation. And there's evidence that some of the pathways that control nighttime waking in response to a full bladder do not mature as quickly in children with enuresis. So this delay in neurologic pathway maturation can cause abnormally deep sleep and failure to wake in response to a full bladder. There's also evidence that many of these children do not make normal amounts of ADH at night. They do not concentrate their urine normally, so they end up with high volumes of dilute urine. Some children have both deep sleep and the failure to wake to a full bladder and failure to concentrate. So here's things you hear. And if any of you have had children with enuresis or friends who had children with enuresis, you've heard this, like, I can't wake him up no matter what. I get him up at 11 o'clock before I go to bed, and I sleepwalk him to the bathroom, but he never wakes up. Sirens can be going off, he doesn't wake up. You'll also hear things like this. I cut back on her fluids after 7. I take her to the bathroom just before she goes to bed at 8:45. I take her again when I go to bed at 10:30 or 11. And still by 2 a.m. she floods the bed. Not a normal pattern of urine production. There's increasing evidence to support a genetic link, meaning that if your mom or your dad had problems with enuresis, you're much more likely to have problems with enuresis. I can't remember it exactly, but it's something like if one parent had enuresis, you had like a 40% risk, or something. If both parents had enuresis, you had like a 70 to 80% risk of enuresis. So I always think, well, you don't want two people who had a history of enuresis getting married and having kids, but then on the other hand, it's not one of those early screening questions we ask when we're dating someone. By the way, did you wet the bed when you were a kid? Just wondering. The most critical thing is, how do we manage? Now, very important to realize that this is a maturational delay, and almost all kids outgrow it. So if you look at the data on enuresis, you'll see that, so you have these kids that are enuretic at, say, age 4, but at age 7 to 8, the percentage drops way down because most children acquire nighttime continence by 7 to 8. And then there's another drop in the kids with enuresis when they hit puberty. Most kids outgrow it. That means that one option is rule out UTI, rule out any problems with retention, rule out problems with daytime continence by doing a simple bladder chart. So you can dip their urine to rule out UTI. You can scan them to rule out any degree of retention. You don't have to catheterize them. You don't want to do anything invasive. So you can dip and scan. You can have them keep a simple bladder chart to see what their daytime function is like. And if their daytime function is pretty normal, and the only issue is enuresis, nocturnal enuresis, then one option is don't treat, just wait it out. And some parents and kids decide, just wait it out. If it's not really bothering the child and it's not really bothering the parents, that's a perfectly feasible option. But what if the child's very upset? What if it's a major stressor for the parents? Then here's what your options are. Alarm therapy is one treatment option, and it's been very successful. And this is the way it works. You attach a sensor to the underpad or the pajama bottoms, and it clips to the child's pajamas, and at the first drop of urine, the alarm goes off. Because the goal is wake that child. Actually wake them up when the bladder is still full. Wake them to the sensation of a full bladder. That's the behavior you're trying to imprint. Now, some clinicians will augment that by walking the child through, having them do a rehearsal of imagining they're asleep, now imagining that their bladder's full, the alarm goes off, they're waking up, they're going to the bathroom, they're getting back in bed. And that seems to reduce the level of sleep. Probably all of you can relate to times when you've had an early flight and it's like, I cannot miss that plane. And so you set the alarm for some ridiculous time, and then you go to bed and you're like, I've got to go to sleep. But you keep waking up, waking up, waking up because your mental alarm has been set. So you can do some behavior modification to help the child rehearse waking to the full bladder and the sound of the alarm. That targets the deep sleep component. DDAVP is synthetic ADH, and it targets that high volume urine production by concentrating the urine so that the child can sleep through the night. A lot of parents do a trial on DDAVP. Can be given by nasal spray or orally. If their child responds well, many parents will use that for sleepovers or for camp or whatever. So 2 major treatment strategies. Alarm therapy targets deep sleep. DDAVP targets high volume dilute urine production. And then the other thing that's really important is counseling for the parents and the child, so everybody realizes this is no one's fault. It's not like the parents have done anything wrong. It's not like the kids doing anything wrong. This is just something that happens, just like Johnny has to wear glasses and so wears braces and whatever. You are having problems waking up when your bladder's full. That's okay, we'll get past this. So mainly taking everybody off the hook. I think that is it for this session. I bet you thought it was never going to end, but it finally did. So remember, this is an overview session just designed to give you the big picture of the different types of incontinence and voiding dysfunction. In the next class, we will walk through how you do assessment for an individual with assessment or avoiding dysfunction, and then we'll move into management. Thank you.